with liberty and justice for all.
Thank you. Welcome to the May 14th, 2025 regular meeting of the Washington Township Care Board of Directors. Public notice for this meeting has been posted appropriately on our website. Tonight's meeting is in person and also accessible by Zoom. I ask that you please mute your system until such time as you need to speak. We are recording tonight's regular section of the board meeting. It will be posted on our website for future viewing. Cheryl, please take the roll.
Mr. Wallace?
Here.
Director Nicholson?
Present.
Director Yee?
Present.
Director Stewart?
Present.
Director Epen?
Thank you. Members of the public are invited to speak during oral communications. When prompted, please state your name for the record, then proceed with your statement, not to exceed 3 minutes, on issues or concerns not on the agenda and within the subject matter of the jurisdiction of the board. Are there any members of the public who would like to speak at this point? Cheryl, is there any written communication? Thank you. So we are going to move on to the consent calendar. The consent calendar consists of those agenda items that the board will approve with one motion unless either a member of the board or a member of the public requests to remove an agenda item from the consent calendar. If any items are removed from the consent calendar, the board will take action on the removed agenda item later in the meeting under the action item heading of the agenda. Does anyone on the board want to remove an agenda item from the consent calendar? Does any member of the public want to remove an agenda item from the consent calendar? Okay.
Mr. President, I move that the Board of Directors approve the consent calendars A and B, please.
Second.
Director Wallace?
Aye.
Director Nicholson?
Aye.
Director Yee?
Aye.
Director Stewart?
Aye.
Director Epen?
Okay. We're now going to move on to the presentation.
Yes, I'm very excited for this presentation this evening. We have some guests with us. As many of you know, we've been celebrating Nurses Week and Health System Week this week. And I'm going to invite Terry Hunter, our Vice President and CNO, to make some introductions. And as we know, what we want to really celebrate are our staff, our physicians, and our volunteers. And everyone has done an amazing job this last year, really working together to serve our patients and to serve our community, especially with going live with trauma. It was really a journey that everyone participated in. But we are successful not because of our bricks and mortar, but because of our staff and our physicians and our volunteers. So I think we're going to hear a little bit from them, but I'm going to turn it over to you, Terry.
Thank you. Thank you for having us tonight. And I, too, like Kimberly, am very excited to have the cream of the crop here representing some of our teams in the health system. So our health system is more than just buildings filled with medical equipment. We are a complex living ecosystem, places where healing happens, where lives are saved, and where compassion meets science. None of this would be possible without the extraordinary people who power our system. In every corner of our hospital and clinic, there are people who wake up each day with a single mission to care for others. Whether it's holding a patient's hand during a vulnerable moment, determining a complex diagnosis, working through the night to repair critical IT outage, or offering kind words to someone in pain, our health system team members embody passion in action. Our mission to deliver exceptional, accessible, and personalized care to enhance the health and well-being of our diverse community comes to life through our employees. Some wear scrubs, while others wear work boots, but they all serve patients. This evening, we want to honor every health system team member, the housekeepers who ensure cleanliness and safety, the food service workers who bring comfort through nutrition, the administrative staff who keep operations running smoothly, and the security and maintenance teams to ensure our facilities are safe. This evening, we want to give you a glimpse into the day in the life of a few of our teams and hear why they choose to work here at Washington. Here is a short video.
Good evening, everyone. My name is Rehan Nouri. I've been with Washington Hospital, now Washington Health, for the last 17 years. Terry did a great job of introducing the mission and vision of Washington Health. And right underneath that on our website, we actually see some of the values. And one of the values of that is excellence. I wanted to share a little scenario about how my role in this organization highlights the value of excellence. But as you may know, I work very closely with the infusion center, and many of these cancer patients end up with very poor immune systems. Many of these patients will then come into the hospital with fever. As we've learned in school, our immune system is the source of protecting our body by producing that response we know as fever. But wait, these patients who've received chemotherapy, they don't have a good immune system, but they still have a fever. What's going on in the body? Something that's contradicting is going on, an oxymoron of sorts. Well, the fact that something that is physiologically impossible or improbable is happening when it shouldn't be happening is a cause of great concern. And this leads us down a pathway of how to aggressively treat these patients when they come into a hospital. Now, this whole time I've been talking, did I mention anything about a medication or any drugs? All you guys are looking at a pharmacist right now, right? Well, that's what I'm here to say, that we, in the pharmacy, we're not just pharmacists. We are a team of clinical pharmacists. It's extremely important to do. Because understanding why we do what we do instills that value of excellence within our organization. And being able to explain why helps us to perform the core duties of our pharmacists to the best of our ability. Compounding of the medication, adjusting doses to fit the needs of the patient, educating patients on side effects of medications, and giving medication information and advice to nurses and physicians on how to best individualize patient care. And the list goes on. And I've been able to implement that value of excellence here at Washington Health, and that's why I've been here for the past 17 years and look forward to 17 more years. Thank you.
Good morning. My name is Jonathan Burdick, and I'm from the respiratory department. I'm here to tell you about the day in the life of a respiratory therapist. I could describe a day in 3 words. It would be unpredictable, creative, and unique. When I come into work every day, I have no idea where I'm going to be. I might find myself in the emergency department, the ICU, the IMC, special care nursery, or my favorite, all of the above. And when you're in so many areas, you encounter a really diverse patient population who suffer from all sorts of conditions and have special needs. Some of the patients I take care of have CHF, asthma, COPD, AD, stroke patients, trauma patients, and I can tell you that no 2 patients are exactly the same. But luckily, we have entire rooms throughout the whole hospital that have respiratory equipment, so I always have the right tool for the job. I have IPV and CPT machines for patients who have too much mucus, high flow nasal cannula and BiPAP and need a little bit more oxygen, and bronchoscopy skills when we really need to get in there and take a closer look at what's going on in their lungs. Often, the well-being of our patients relies on the creative collaboration between me and my colleagues to find the treatments that work best for them. So between the unpredictability of my shift and the creative collaboration between me and my colleagues, this creates a unique experience for me every time I come to work at Washington Hospital, where I can be there for the first breath of a neonatal or the last breath of a loved one, all on the same shift. And if you ever come to Washington Hospital and you're having an emergency, you can rest assured that a respiratory therapist is on the way.
Thank you.
My name is Sonia Gibson. I'm a tele-charge nurse. I've been with the organization for almost 15 years now. I've been tele-charge for probably about 10 years. I was excited to take a position here as a new grad just many years ago. I was going to be serving the community I grew up in. I've stayed this long because I really appreciated the effort, the work, and the care that the coworkers around me have provided to our patients. I've seen the community change a lot in the last 15 years I've been here. They're coming in a lot more comfortable, a lot more social issues, et cetera, and COVID didn't help that. So I really try every day as in my role to provide myself as a resource, not only as a resource to the staff members, whether that be they can provide more time with their patients at bedside, running errands for my staff members, or I am a resource for the family. Whether they're angry, whether they're sad, scared. Just the other day, we had a very demented patient who was very scared. So I spent a lot of time with her, just trying to comfort her, make sure that she was safe, that she felt safe. So most of my day that day was spent with her. And so little moments like that I can appreciate and value because while I'm not at bedside 100% of the time, I can still provide my care, not only to my coworkers, but also to the community.
Thank you.
Hi, I'm Julie. I'm since 2019. I choose Washington Health for my career because of diversity in care and compassion I experienced here as a. Thank you.
Hi, my name is Garrick. I work in the imaging department. October 24th this year will be my 20-year anniversary. I was born at Washington Hospital, January 2nd, 1970. So I have the most seniority. I wanted to just mention my motivation with patient care. My motivation comes from my grandmother. I had her in my life for 33 years. I had the privilege of being by her side when she passed. And to this day, I remember our doctors, the nurses, kindness they showed to my grandmother and to my family. And so that is what I want to bring to every patient that comes to Washington Hospital. I want them to feel seen. I want them to feel that we heard them. And when they leave, I really want them to feel like we helped them. And so she continues to be my motivation. And during the 20 years, I've seen a lot of changes. I used to do everything with one CT scan. We are inpatients and outpatients. As the facility grows, as the services we offer grows, my motivation stays the same and my goal stays the same. To make the patients feel heard, seen, and helped. Thank you.
Thank you.
Hi, my name is Katie Ng, and I am a physical therapist. Thank you for the opportunity to speak to you all tonight. I've been working here at Washington Health since February 2020, a month right before COVID.
Thank you.
I'm here to just share that I love my job. And I love being able to serve in a role that has an impact on the patient experience while they are in our. When I treat our patients, I picture them as my grandmother, father, as my own best friend. And I ask them about their hobbies and what brings them joy. And I intertwine those motivations with their mobility potential, and I do my best to help them hold on to their ability to do the things that they love. Our mission: exceptional, accessible, personalized care. I can confidently and wholeheartedly say this about our rehab team. We provide. We care so much that just today, I comforted my colleague who shed tears for our patient who just experienced a traumatic injury. 22-year-old with a spinal cord injury. Can you imagine if someone in your family could never walk again? As healthcare practitioners, clinicians, rehab specialists, and as parents, both of us treated that patient and his mother and his whole family with the utmost compassion, empathy, and honesty. And we care so much that our OT that specializes in the SEN spends extra time to teach new parents how to feed their baby. Can you imagine if we didn't know how to feed our babies? Now, can you imagine how comforting it must feel someone to actually sit down with you and patiently show you? We pride ourselves in the work that we do. We see our patients on their worst days, in pain, in fear, and sometimes in loneliness. And we help them move. We help them see what they can still do, and we help them know that they are a part of our community.
Thank you.
Thank you all. I think you can hear from these stories. This is a sample of what I've experienced day after day at Washington Health. We've got amazing people that make up our team, that are dedicated, that are engaged in the work, and the stories of the impact that they have for the lives of our community are amazing. So thank you to each of our caregivers that have helped us with this presentation, as well as the communications team who helped us with the video, and to the many people that bring their knowledge, skills, and compassion to embrace care here at Washington Health. Happy Health System Week.
Thank you.
Thank you.
Thank
Thank you all. Thank you.
Keep at it.
Yeah, thank you.
You need it open.
Thank you, Terry. Wonderful.
Okay,
I think next we have Dr. Soleil for the medical staff report.
Hi, good evening, everybody. I have to apologize, I'm stuck in traffic, so I'm not going to turn my camera on, or you're going to get a really weird angle of my face, which you don't want to see probably. Those were great presentations. It's very inspirational. I think we're having a great week. The food trucks were a big success. The food was awesome. And I'm looking forward to getting my new jacket as well. On to my report. The medical staff census, we have a grand total of 667 practitioners on staff. Of those, about half are active, 367. 2 are administrative, 36 advanced practice providers, 98 ambulatory, 9 consulting, 11 courtesy, 1 leave of absence, 80 provisional active, 12 provisional advanced practice providers, and 48 consulting, provisional consulting, with 3 with temporary privileges. The medical staff, as well as the bylaws committee, is working on updating the bylaws, and we're currently in the middle of getting a vote from the medical staff to approve that. And I will update the board as soon as we get that final tally, but it looks like it is going to pass. I think we've discussed those changes before, but again, I will discuss them at the next opportunity. The biannual medical staff dinner dance is coming up next month to honor Dr. Erasmus, and we're encouraging all the doctors to attend and looking forward to this fun event. Then I believe that is all I have of any interest, unless anybody has any questions for me.
no questions, Dr. Soleil. Thank you so much.
Thank you.
Well, thank you, everyone. Have a good evening.
Drive carefully.
Thank you.
All right, next we have Sheila Vijay, our Service League report.
Good evening, members of the district board. Again, a warm greetings on behalf of all our volunteers. I'm pleased to report that in April, 248 Service League volunteers contributed 2,914 hours across various hospital departments. To sustain this level of service, we continue to welcome new volunteers through information and orientation sessions. On April 12th, we hosted a volunteer orientation with 32 attendees, including 12 adults, 15 college students, and 5 high school students. We also held a high school information session on April 14th, attended by 53 students to highlight the many ways they can get involved as volunteers. We held our $5 masquerade sale at the end of April and are pleased to report that it raised $6,100 for the Service League. My thanks go out to the many volunteers whose hard work ensures the success of this event, and I'd especially like to recognize Shuri Gamado, whose tireless efforts in promoting and managing the sales are deeply appreciated. Volunteers continue to play an active role throughout the hospital, offering support to patients, families, and staff. Since its launch, the Birthing Center Tour program has continued to thrive. From December 2024 through April 2025, volunteers led 26 tours for more than 150 expectant mothers. These tours help families become familiar with our facilities, and they feel more confident as they prepare for their new arrivals. Feedback from participants has been positive, with many expressing appreciation for the clarity, reassurance, and personal touch provided by our volunteers. The Wolf Canine Therapy Program will host its second community education session on June 27th. This presentation, featuring Dr. Elizabeth Lynch, DVM, will focus on safe travels with your pet. As summer approaches, this session will offer helpful tips for a safe and stress-free journey, whether it's a quick trip or a longer vacation. And lastly, we are excited to announce the upcoming launch of Bingo Size, a 20-session health promotion program that blends bingo with light exercise. Starting June 2nd, sessions will take place twice weekly on Mondays and Wednesdays. We thank the Trauma Center team led by Garrett Coders for bringing this engaging program to life. And that concludes my report. Please let me know if you have any questions.
Thank you, Sheila. Any questions, anyone? It was good seeing you on Monday.
Yes. I'm everywhere, I think.
Yeah, you are.
Yes.
Thank you.
Thank you.
Good to see you too. Have a good evening.
Oh, hold on, Sheila, one question.
Yes.
Can you tell us how many are on the waiting list? Are there high school students on a waiting list to become volunteers?
Currently, we have closed. There were about 600 and 700 high schoolers on the wait list. We have currently closed that program because there were too many of them. And we are reaching out to them, making sure they are absolutely interested and serious about, coming on board. And that's what we've been doing. So currently it's closed. We still have about 600, 700 on the wait list. We are trying to get rid of, all those students because they've all either moved away or they're no longer interested.
We're redirecting them.
Yes, or maybe they'll finish college and come back again to us.
Oh, okay.
Yeah.
Thank you.
Thank you.
Thank you. All right, next up, we have Mary Beaumont, our Assistant Vice President and Chief Quality Officer, and she is going to talk about the Quality Dashboard quarter ending March 2025.
Thank you, Kimberly. Yeah, so tonight I will be presenting the Quality Dashboard, and this is a reflection of the first quarter of the calendar year. So all of the data and events are associated with January, February, and March of this year. Starting off with my infection prevention metrics, hospital-acquired MRSA is, we've done well on this. Towards the end of last year and beginning this year, we've luckily been able to decrease this because we had some concerns about it last year. As you could see, we had a couple of patients that had MRSA in their blood. And we have sustained this being at 0 right now. We've looked really carefully at how we're screening these patients. And if they are screened positive for MRSA, what are we doing to help them not have an active infection? Are we isolating appropriately, et cetera? So the teams have been working really well on that. And again, second quarter with 0 MRSA in the blood. And then moving into catheter-associated urinary tract infections, otherwise known as CAUTI. I'm happy to report that we also have continued to sustain 0 at this for the second quarter in a row. Well, we had some issues on it in mid-2024. We're now broaching on about 300 days of not having a CAUTI. So really good quality care with making sure that patients only have a catheter in place if they need it, if it meets for medical necessity. And if it does, are we doing all the interventions to make sure that the patient's kept clean and that the bag is handled appropriately, et cetera. And so the outcome of all that process, we've been able to sustain for 2 quarters and hope to continue to do that. And we have the same success in CLABSI, which is central line associated bloodstream infections. Again, really have had some great sustained improvements with this. We've actually had some community hospitals and reach out to us to ask us, what are some things we're doing to prevent CLABSI? And we're heading into almost 3 years without a CLABSI. And it's very similar to the things that we do to prevent CAUTIs. And it is making sure that central lines are placed very carefully. We audit those and how they're placed, and then that when they are put in place, they're only left in as long as the patient needs them, and that they're maintained very carefully while they're in place. So when you have data that is sustained for this period of time, really makes me feel confident in the quality of the process that we're doing to prevent CLABSIs. We have great surveillance methods that we use here. So I feel very confident that the data is valid and, again, sustained 0 CLABSIs, which we hope to continue. Surgical site infections for this quarter, we did have one in the colon at a patient who had a colectomy. And this is a metric that we monitor the patient when they come in for surgery. We'll monitor them for up to 30 days after they leave. And there's a couple ways that we can identify these, and we were able to identify this as the patient returned to the hospital and got IV antibiotics and has done well as a result. But again, overall, we tend to do very well in this area. Then we also had an increase in our surgical site infections related to abdominal hysterectomies. And this is a procedure that, of course, could be high risk for patients to develop a surgical site infection. We have sustained a long period of time without this. So when we did get 2 cases in 1 quarter, we took it very seriously and looked to see what are some things, did any of these 2 cases have something in common? For example, share the same pathogen, or did they have surgery around the same time? Because we just want to make sure that it wasn't acquired here. So we've done a root cause analysis. These cases will go through peer review, but in the immediate findings that we've seen, there isn't any correlation between the 2 other than the fact that they happened in the same quarter. We have had a lot of detail in how we reviewed the cases. These patients were both very sick and had complications related to having, they had cancer, and then we came in and we did this high-risk procedure for this area, and they were complex cases, and unfortunately resulted in a surgical site infection. But we also want to be clear that we do look beyond the complexity of the patient, and we look to make sure that, are we doing what we should be doing with our turnovers in the room? Are we making sure we're following all of our OR standards? It doesn't look like this was anything internal. It was just 2 unfortunate complex cases. And then moving into our C. diff, far lower than expected. We had 1 C. diff case in the quarter. CDC predicts that we would have closer to 10. So again, we're sustaining this far under what's expected for a hospital of our size and type. This is an outcome metric for how well we monitor and use our antibiotics. We have a great antimicrobial stewardship program here that is run very well, and we're very careful with the antibiotic use. And then when patients do come into the hospital, if they have any symptoms that make us think they possibly have C. diff, these patients are isolated and with strict precautions. And again, this is a great outcome for all of those processes that we use. And moving into our national patient safety goals, starting off with hand hygiene, very happy to report that we've been able to sustain a compliance rate of 98.6. Even Joint Commission, which has a strict standard, holds us to 90%, and the World Health Organization holds us to 70%. So we've been able to supersede all of those and sustain it. Again, we've really put in a lot of work to making sure that the staff is trained. We have a very large volume of observations, so this number is, we're very confident in its accuracy. We have managers who are constantly going around reminding people to wash their hands. And again, lots of participation across the hospital and disciplines for collecting the data. We do collect the data electronically and have really had some good sustained success with this. May 5th was Hand Hygiene Day, and we took that opportunity to do some quizzes around hand hygiene, and we did a prize and a drawing, et cetera. Just any opportunity we can remind people of the importance of hand hygiene, we try to take advantage of, and I think we've had some great process with that. Moving into our nursing sensitive indicators, starting off with injuries related to patients falling. We are far below the benchmark, last available benchmark on this, which is from ND and QI. Our magnet benchmarking was 0.58, and we're at 0.05, so far under the benchmark. This is a reflection of one fall, a patient getting up to go to the bathroom, which is often the cause for falls, especially when people like to maintain their independence and trying to get to the bathroom. The patient was found in with a minor injury, and so that does qualify for this metric. But again, overall, if you look at our patient days, we're far below the benchmark. These patients are placed very carefully in the hospital where they can have high visibility if they're high risk for falls, do frequent rounding, never passing a call light that where a patient needs an attention. All of those things really impact your falls rate, and we're doing great on that. It's very similar when we move into hospital-acquired pressure ulcers, otherwise known as bed sores. Our last available benchmark for this is 1.39. For this quarter, we were at 0.91. This is a reflection of one pressure ulcer that was identified on surveillance. And we do a surveillance very frequently in multiple units throughout the hospital with qualified staff that can stage and recognize these ulcers and make sure that they're documented and taken care of immediately. So out of 110 patients surveyed, only one had a pressure ulcer in a chronically ill patient. And again, keeping us well below the benchmark. Moving into our readmissions, I would say that this is probably the most challenging area that quality has been dealing with for this first quarter. We did have a large increase in census and a really acute, highly acutely sick patients. And I think we see this reflected in the readmissions data. I'm going to go through the first four medicine related types of readmissions, and because we're following the interventions that are very similar for all disease states. So I'll go through all four of those and then talk to you a little bit about our plan for what we're doing to reduce readmissions. So starting off with heart attack, otherwise known as AMI, our readmission rate was 21.1. This is higher than what CMS expects. They expect something more around 14.6. It's a reflection of 4 patients coming back who originally were here with the heart attack and returned within 30 days. Moving into our next slide. For pneumonia, this one was, again, by far the most complex, challenging area that we had even out of all 4 of these types of conditions. We did have 24 patients return. That put us at a readmission rate of 26.7, pretty significantly higher than what CMS would expect, which is closer to 15.3. So these 24 patients, we have looked at each one of them in detail. We are very lucky to have Dr. Akawili overseeing all of the readmission cases. She reviews them all and gives us insight, especially helpful when we see big increases like this with pneumonia, considering that she's a pulmonologist, and she's helped give us some targeted interventions, which I'll review in a minute. And then our next group was heart failure patients, also a little bit above the benchmark. We had 11 patients return, giving us a readmission rate of 20.8%. This is higher than CMS national benchmark, which is 18.8. So I just want to go over COPD next, and then I'll talk about what we're doing to prevent this. For COPD, we did have 8 patients return. That gives us a readmission rate of 29%. CMS would expect that to be closer to 18.3%. So that's 8 patients out of 28 returning. So as you can see, before I move into the surgical ones, all these groups had an increase. And again, high census, high acuity, but nevertheless, we have to look at these cases. And one of the things that I think that we have learned pretty much about readmissions is that while we may do the best in the acute care setting to prepare these patients as they go back home or go home with home health or go to a SNF, we recognize that we have got to be offering them more post-acute support, especially in the time before when they leave the hospital, before they get to their primary care doctor. We do set up appointments for them to get to their primary care doctor. We are having members of the transitional care team speak to the patients by phone. We're recognizing that we need to take that to another level. So we've been working with a group called OnClick, and they are a group of medical staff providers, and they have different disciplines offered that find these patients and give them extra support as they transition out of the hospital before they get to their doctor and before they can get in and get other things that they need. Like, for example, if they can't get their medication right away, they'll help do that. They'll make sure that they got the medication after they left. They'll make sure that they get to the doctor on time. And then they will work with the attending physician and to make sure that we're all following the patients closely and giving them that extra support. And they do this even with patients who go home with home health. That is our biggest category of the patients that returned. It is patients that go home with home health. So the patients do have home health support, but there are other things that we can do specifically to help the patients that are high risk for readmissions. So this program is going to go live starting next week. We've had good support from the medical staff on this. We've educated on them with them, and Dr. Romano has helped lead those. Our transitional care team is working with Dr. Akawili. And so I'm really looking forward to seeing what this extra support will offer our patients. Attendings absolutely still manage their patient post-discharge. Attendings can say that they don't want to participate in the program if they feel very confident that they can help out the patients and give them that extra support. So a lot of good continuum of care interventions, and that's what we're hoping will reduce this. We do not have the same problem with surgical procedures with readmissions. So just to move into the next slide with our coronary artery bypass graft patients. This is otherwise known as patients who have cabbages. We've been able to sustain that these patients are not returning to the hospital. Out of 4 cases, we had 0 patients come back. And so that's less than expected per CMS. And then moving into our inpatient elective primary total hip replacements along with knee replacements. For this patient population, we had 1 patient come back out of 20. We clearly do a lot more than 20 procedures, but these are patients that come in as inpatients. So they're not a patient who comes into the hospital, stays one night, and maybe leaves as an outpatient. These are patients who are typically sicker and more complex, and we recognize in the beginning they need to be an inpatient. So again, one of those patients that puts us pretty much right at the benchmark, just a slight difference from 5% to 5.1. So pretty much expected to on occasion have 1 come back, and we did. When we move into the next slide, which shows all of the knees and hip replacements that we did, which is a volume of 325, we only had 1 of those patients come back. This is the patient population I was referring to, which is their outpatient. So again, not as sick, not as high acuity, still incredibly remarkable that only 1 came back out of 325. Our readmission rate was 0.3%. CMS expects that to be much higher at 5.1, as I mentioned. So surgery is doing well, but we really recognize we've got to focus on getting better medical management and support to these other patients after they leave that are high risk for readmissions. And I'm happy to answer any questions.
Yeah, Mary, this is Bill. Are there common themes among the patients who are being readmitted? All of them get home health?
So there are common themes, and no, not all of them do get home health. But of the #1 patient group that does come back to us with those, especially pneumonia, it's interesting because you would think it would be the patients that are coming back who didn't have home health, but it's the patients who had home health are a #1 group. And then we move into the ones who didn't have home health. So the common theme is, yes, that these patients are actually very ill. Most of them tend to be over in the late 70s, early 80s, especially in this quarter. We had many of them in their mid to late 80s. A lot of diabetes management, a lot of polypharmacy, like they're on a lot of medications. We do have patients in that group that returned, especially with pneumonia, that would probably be great candidates for even palliative care, some for hospice also. So we're working, on with the team there in palliative care to maybe get these patients into programs that are more well suited to give them good quality of life, but avoid them having to keep coming back to the hospital. So it's really the diabetes and just the multiple chronic illness.
How many patients who are readmitted are ones that were recommended for skilled nursing yet declined?
Okay, so that's a good question, and I don't have the specifics on that, but I can tell you that in general, we very rarely have a case, unless a family member refuses, where they should go to a SNF, they meet for SNF, they qualify, Medicare pays, but we send them home with home health anyway. That next to never happens. I can't even remember a case that's been escalated to me about that. So I do feel confident that if they need SNF, they get it.
Okay, that's good, that's good.
But we are aware of what a problem this is.
How many of the readmits come from home or versus a SNF?
So I think I actually do have that. And it's actually the majority. Do you mean for arrived, like their disposition that they came in from was from home versus a SNF? That's what you mean?
Right.
Yeah. The vast majority, I'd say over, and this is a rough estimate, over 80% are from home and not a SNF. Okay. So it is something we look at with our high quality networks because we would be very concerned. Well, we always want people to send patients to the ED if they need to go. And then we've always been very clear about that at Washington Health. And if you need to be admitted, you're being admitted, And so one of the reasons why we really look at the SNF is because we want to make sure the quality of care they're providing at the SNF is that they're managing these symptoms before they get out of control, right? So we do look at that data closely. In fact, Dr. Akawili is actually doing on-site visits at the skilled nursing facilities, really developing great relationships with the medical directors because she has the same concerns and wants to make sure that they're following pneumonia prevention bundles, for example, things like that.
Thank you, Mary. It's a tough problem to solve.
It is. Yeah, it's very complex.
A lot of different solutions altogether combined.
Yeah. Thank you.
Any other questions? Okay, thank you, Mary.
Thank you.
Thank you. Have a good evening.
All right, next we have Ajay CL, who's going to present the March 2025 financials.
Good evening. So March was an interesting month. Our operating stats are mostly better than budget, but the net income was below budget. And there's a few issues, and we'll go through those. Inpatient census, discharges, patient days, ALOS, all better than budget. Off days were below budget. And if you recall the discussion we had last meeting when we were going through this, that we're doing a much better job managing ops and getting them to the right level. Dr. Sadiq, Mary Bowman, great leadership, and I think really doing excellent work. And that we've continued to see that in April, and so it's been a couple of months now, so that's good. Continuing on with the stats, next page, CMI, deliveries, cath lab, outpatient cases all higher than budget, surgical cases and ED visits below budget. Surgical cases, next slide, were below budget in ortho, neurosurgery, and other, and favorable to budget in cardiac surgery, vascular, and endoscopy. Cath lab cases were higher by 19, with the IR being the most favorable. In terms of FTEs, next slide, we flexed well, and we're 56 FTEs below budget. Year to date, we are 102 FTEs below budget, and on a FTE per adjusted occupied bed basis, we're also better than budget. Doing well there. Next slide. Gross revenue was $4.2 million higher than budget. Good volumes, good gross revenue. and maintains the year-to-date trend. Contractual allowances, $1.1 million higher. Provision for bad debt and charity care were about $1.4 million higher than budget. Payer mix shows 73.5% was from governmental payers, and the PPO HMO was about 23%. So I want to just take a little digression here and just talk about our contractual allowances. And I know we've talked about those here for a while. We're continuing to refine our model. And we embarked on a journey a few months ago to move to a more modern model. We've had that same model. It's been dependent on, so it's really, you do these analysis based on our paid claims, and then you look at how they filter through the system, and then what we expect as a result. Our model was that we started off like 4 months out, so the first claim that month we were looking at was 4 months out. What that does is, if you're making changes, for example, this OBS stuff, that doesn't get reflected into our revenue stream, even further out. And then we look at 12 months. So it was really starting from, let's say we're in April, we're looking, so we first take out 4 months, so we get to November. So we were looking from November to last December. So that's the area of claims that we were looking at. And as you can tell, that's getting pretty dated. So we're trying to move this forward, bring this to a more, to more real time. And so we've now got a consultant helping us, a company called Toyon, who do this for a fair amount of local hospitals. But that's not the ultimate place. We are going to move to a much more digitized, 21st century model that probably more than half of the hospitals in this country use. That probably won't happen till early next year. So that's where we're going to end up with this eventually. And that will then provide us much better insight into our data. And as we're going through the budget process, we'll talk a little bit more about this later. So I just wanted to tell you a little bit about where we're headed with this.
So this will be a tool to allow us to better predict
what our revenue
for an individual patient.
Right.
While they're here,
or
close to discharge, or how soon after discharge?
Yeah, so, we will start doing a much better job on predicting what that will be. Because, we'll be looking at newer data. What happens is also, so there's two things that happen, right, in our revenue model. One is that our patients who are here, right, and how they will price out based on their payer mix and their payer and whatever else. The second part of it is how that old AR, all the stuff that we haven't collected,
right,
how that's liquidating. So we have to have a way to figure that out too. So those are the two things that happen, and then we come up with our revenue number. So these tools will really help us understand what's going on, so we can do a better job of predicting it. That make sense?
No, and it makes perfect sense. It's good that we're moving towards that kind of system that will allow us to do that.
Yeah, I think we'll all feel a lot better.
It'll help us know how much we're going to get paid.
Right.
The real question is, will it help us get paid more?
Well, yes and yes, right?
Better data, better negotiation.
Right. So coming back to our data, we had $55.1 million in net revenue, which was $1.3 million above budget. Our operating expenses were also higher than budget by $2.9 million, and OpEx was higher due to a few things. First of all, is we're truing up our pension and OPEB costs. And those are under expense so far to the tune of about $5 million. So we are catching up to that based on Milliman's latest study, so we're trying to catch up for that. So we'll see this for the next 3 months. So we'll see that in April, May, and June also.
It'll be five a month?
No, it's about it's 5 in total. So what we have in here is about 1.1-ish. So that will.
That sounds a whole lot better.
Yeah, don't make me sweat any more than I need to. I mean, the other thing that's happening is our new employees are coming in at higher rates than what we budgeted. Our premium pay is still fairly high. So those are the things that was another $700K. So between those two, that's the majority of what's going on in our OpEx. So net operating income was a loss of $470K against a budget of about $1 million. Non-operating margin and non-operating income was higher than budget by $437,000. So we have a net income of about $1 million against a budget of $2.1 million. On the next slide, we show the FASB format. I won't spend a whole lot of time on that. It roughly projects the same story, albeit a little worse. And then the last slide here, I'll just point out our EBITDA in the middle there. That's what I tend to look at. We had $3.1 million of EBITDA against a budget of 5.7% versus 8.5%. On a year-to-date basis, we have EBITDA of $30.2 million versus a budget of 35.7. So that's effectively our story for the month. We had some costs show up that we weren't expecting, and we had to take that into consideration when we were looking at this.
Yeah, it was puzzling when I looked at this because we did better from all of our operational standpoints. Our average length of stay was better. Our case mix index was higher.
Right.
Our FTE for AOB was better.
Yeah.
Everything was
all the
working
operating
well.
stats are doing great.
So what specifically led to the higher cost?
So it's those. Like I said, it's the
Employee cost,
it's all around our employee costs. It's about our benefits. It's the defined benefit plan that we have to shore up.
Yeah.
And it's also related to our premium labor. And then, we've also, during the start of the trauma program, we have some issues. We've been accruing higher costs related to the author trauma and things like that related to budget.
All right.
So, but that's been in there for the almost the full year. But between those three items, that's what's causing us to.
It's all people.
It's all, yeah, it's all really, it's either physician salaries, it's our employee salaries. That's where it is.
Yeah, we've seen higher claims, I think, in benefits too.
Right.
Yeah.
That was the other thing.
Yeah,
So not only.
you're right. Even the
we're
benefits.
seeing not more claims, but more complex.
Complex.
So our own employees or dependents are unfortunately are sicker. And then the pension, and then as Ajay said, all the other pieces.
Any questions? No comments?
Helpful.
Thank you.
Yes, so I will now talk a little bit about April, in 2025. And again, Ajay said very well in terms of continuing, Dr. Sadiq and Mary Beauron have been continuing to work on the OBS and work with all the physicians and staff within the health system to make sure that patients are in the appropriate level of care. And as you can see, we came in at 208 days, which was 209 days favorable to the budget of 417. It's a little bit higher than the previous month, but that's going to go up and down. Again, I think that there's going to be a range that it is in, but I think we're just working a lot with education and the processes in place for this. And again, we're continuing to see more consistency and predictability over the past couple of months. Moving on to the total gross revenue, it came in at $223.3 million for April. which was favorable to the budget of $214.3 million by 4.2%, and favorable compared to April of 2024 by $28.8 million, or 14.8%. Year-to-date revenue was favorable to the budget by 2% and favorable to last year's year-to-date by 11.5%. Again, this shift is also helping in our gross revenue. Moving on to trauma, we had 153 cases for April, which was favorable to the budget of 105 by 48, or 45.7%. Year-to-date, cases were favorable to the budget by 447, or 40.4%. As I've continued to talk about, inpatient trauma cases for April at 53 were unfavorable to the budget of 64, but the inpatient revenue per case was favorable to the budget by 33.7%. Outpatient trauma cases of 100 for April was favorable to the budget of 41 by 143.9%, and also our outpatient revenue per case is also favorable to the budget. So we'll see in the next year's budget, we'll be able to have a better idea of the types of trauma cases too. Here you can see our activations for the 153 cases that we saw in April. We had 8 alphas, 37 bravos, and 108 deltas. And you can see year-to-date where we stand in terms of that breakdown. Once again, falls seems to be the highest type of cases, trauma cases that we saw. We saw 67 falls, which is about 44% of the 153. Moving on to our gross revenue, trauma gross revenue of $17.3 million for April was favorable to the budget of $13.2 million by 4.1 million, or 31.4%. And year-to-date was favorable to the budget by $27.7 million, or 19.4%. Moving on to our inpatient gross revenue, it came in at $137.7 million, and it was favorable to the budget by $16.5 million, or 13.6% less than March due to one less day, basically, but 22.5% higher than April of 2024. Year-to-date, you can see gross revenue was favorable to the budget by $33.7 million, or 2.6%, and also favorable from last year's to date by 15.2%. Looking at our outpatient gross revenue, that came in at $85.6 million. It was unfavorable to the budget by $7.5 million, or 8%, due to less observation days, basically, as I mentioned, but $3.5 million, or 4.3%, favorable to April of 2024. Year-to-date revenue was favorable to the budget by $10 million, or 1.1%, and favorable to last year's to date by 6.5%. Looking at our inpatient length of stay, came in for the month of April at 5.16, a little bit higher than last month, but still was favorable to the budget of 5.31 by 0.15, or 2.8%. Again, a number of that was driven by lower observation days, and was favorable to April of 2024 by 1.06, or 17.1%. Looking at our April discharges, it came in at 1,072, which was favorable to the budget of 936 by 136, which is 14.5%. Again, a lot of this is driven by lower observation days, and year-to-date discharges were consistent with the budget by 54, or 0.5%. We did have 11 patients that stayed over 30 days during this month. We have seen more sicker and more complex patients here over this last couple of months.
I was just curious about the observation.
Yes.
Why is that?
So because
As I recall, it's nice to have it down.
right, it's nice to have it down. So instead of
Why is
patients,
it going down?
well, so Dr. Sadiq and Mary Boron have been working on initiatives to make sure that when a patient comes into the emergency room, they are placed in the appropriate level of care depending on what, the lab tests and other tests are showing in terms of that from as quickly as possible from the beginning of their stay. So 4 of them, if they meet the criteria to be inpatients, they're placed directly into inpatients, and you're seeing that in those patient days versus observation or outpatient. Patient days. So patient days of 5,471 were favorable to the budget of 4,970 by 501 days, or 10.1%, and were 903 days, or 19.8% favorable to April of 2024. There were 292 days for trauma patients. Without trauma, the patient days were favorable to the budget by 703 days, or 15.7%. Moving on to the inpatient average daily census, came in at 182.4, which was favorable to the budget of 165.7 by 10.1%, again due to higher patient days and admissions, and favorable to April of 2024 by 30.1 or 30.1 equivalent days. All right, moving on to surgical trend. Total surgeries in April of 534 were unfavorable to the budget of 542 by 8, or 1.5%, but were 69 or 14.8% favorable to April of 2024. Inpatient surgeries came in at 289, were favorable to the budget by 23 or 8.6%, and outpatient surgeries at 245 were unfavorable to the budget by 31 or 11.2%. We did do 7 TAVRs in April. Next, you can see the breakdown on the surgical. I just want to say it's surgical and endoscopy is both included in these numbers. As you can see, orthopedics is down, and that's really continuing to see the move of certain joint patients to the ASCs on that side. Again, general and vascular were down about 7 cases each, and other was down 22 cases, and that had to do a great deal with ENT and some OBGYN. We did have a busy neurosurgery month with 35. Moving on to cath lab. Our cath lab cases of 196 were unfavorable to the budget by 8, or 3.9%, and basically consistent with April of 2024. Cath lab inpatient cases of 115 were favorable to the budget by 2, or 1.8%, and cath lab outpatient cases of 81 were unfavorable to the budget by 10 or 11%. We did 4 Watchmen were performed in April. Next, you can see the breakdown. This month, as Ajay said, the previous month was higher in interventional, it was lower. This month, at higher in neuro, IR, and cardiac. Our deliveries continue to be busy. They came in at 127, which is favorable to the budget by 8, or 6.7%, and were 14 or 12.4% favorable to April of 2024. Our C-section rate, as you can see there, just compared to total deliveries, was 29.9%. Looking at our non-emergency department outpatient trend, there were 9,562 visits, was favorable to the budget by 2.9%, or 273, and also favorable to April 2024 by 494, or 5.4%. We saw, in terms of the areas that had favorable performance, cardiac rehab was above, the visits were above budget by 16.2%. Rehab was above budget by 132.4%, and infusion center continued to be busy, and that was up 15%.
How they doing space-wise?
In infusion?
Yeah.
They're actually have been really managing well. I know they've been working on a new scheduling system to try to maximize the use of their chairs. So I think they're continuing to be able to and they have expanded hours too, so. But I will tell you, they're very excited for their new space to open.
They are.
Yeah, yeah, very much so. Moving on to our emergency department visits. We saw 5,220. It was unfavorable to the budget by 303 or 5.5%, but favorable to April of 2024 by 5.9%. Year to date, it was unfavorable to the budget by 2.6%, but do want to mention that compared to last year at this time, we are seeing 6.5% more visits. So we're more than last year, but not as high as what we had budgeted. And again, I think some of this is just understanding trauma too. And really what we saw more were the more critical and the trauma patients from that standpoint. And you'll see some of that in the revenue. Here's the gross revenue recap. Aligns quite a bit with the volume in terms of surgical services was unfavorable to the budget by 4.8 or 12%. Again, we saw less cases and more of the endoscopy cases in that. Also, cath lab revenue came in at $2.3 million or 21.6%, which was favorable to the budget, even though cases were down 3.9%. And that's really due to the mix of cases. We saw a lot of neuro and cardiac cases in the cath lab. Again, birthing center also was up 10.6%, was over budget in terms of the number of deliveries. And as you can see, with the emergency room, even though our visits were below budget, we did come in favorable to the budget by $2.5 million or 16.5%. And again, this had to do with the types of visits we saw. Moving on to the payer mix, you can see we sort of was in the different areas, unfavorable and favorable. Again, government-sponsored, though, overall was unfavorable. If you look at Medicare, we had less Medicare but more Medi-Cal compared to budget. And we're seeing more of the Medi-Cal and the trauma patients, too, especially this month. Also, you can see HMO was favorable, but PPO was below budget and not favorable, coming in at 18.9%. And a little higher also in self-pay, though, again, with self-pay, that has to work its way through in terms of, especially if they're trauma-related. Moving on to the productivity indicators, our productive FTEs were favorable to the flex budget by 53.7 or 3.6% at 1,510.1 FTEs. Looking at non-productive, it was also favorable to budget by 9.5 or 4.8%, coming in at 197.5 FTEs. Looking at our total FTEs, we're favorable to the flex by 63.2 or 3.7%. Total FTEs per adjusted occupied bed came in at 5.78, which was favorable to the budget of 5.92 by 2.5%. Moving on to our radiation oncology center treatments. It came in at 385. It was unfavorable to the budget by 11 or 2.8%, but favorable to April of 2024. The other piece we always look at is on the next page. We received 35 new referrals, so continuing to see a good number of referrals coming in for radiation services. I also saw 25 new patients in the clinic. And April's conversion rate into patients that will need treatment at this time is about 26%, which is an increase from last month of 14%. Looking at our outpatient statistics for Washington Health Medical Group, unfavorable to the budget by 455 or 2.6%. And really there were two areas that we saw this. We did have a physician that was out on a leave of absence on one of our primary cares for family reasons, and we have additional physician in Warm Springs that is also still ramping up. We did see in cardiology and Gastro was also above budget in terms of those areas that offset some of the primary care. Looking at our development corporation statistics, it came in favorable to budget at 2,474. It was favorable by 7.9%. The rehab center was favorable to the budget by 9.5%. Our Washington Outpatient Surgery Center was favorable to the budget by 9.2%. And Peninsula Surgery Center was unfavorable to the budget by 27 cases or 23%. So the two were up at PSC. They're still working to have additional physicians join over there, so I know they're out talking to other physicians. Looking at one of our key financial statistics, our days cash on hand, we did see a decrease from March, and we saw a 7-day decrease from 139 days to 132. And this was really driven, April had 3 pay periods, so we saw 6.6 million in terms of that, and also saw a little bit of a less gain on investment. As we know, the market has been somewhat volatile. So that, and then charity care for the month of April came in at 133,000. So those are the statistics for April. Any questions? It has some ups and downs. We'll move on to Employee of the Month. All right. I'm very excited to introduce our May 2025 Employee of the Month. It's Sonia Panda, our digital marketing specialist. So all this work that we're seeing with videos out on social media and all the work is really because of Sonia. She is our digital marketing specialist, and she is the face of both our marketing and communications department. She brought what?
A lot going on.
There is a lot going on, and as I said, she's really, I think, I get a lot of comments from the community about just seeing our videos. I mean, we had our physician, we had nurses, we've had a lot of different videos out there. Excuse me. Sonia brought several years of healthcare industry experience to Washington when she began her employment here in May of 2023. As a member of the marketing and communications team, Sonia juggles many projects at once, very many, and has directly impacted our digital footprint and our community-facing image. All of our social media channels have increased in followers and positive responses. Whether she's taking photos, creating fun videos, crafting flyers, managing social media accounts, or assisting with new brand assets, Sonia maintains a pleasant and professional demeanor. In creating social media content, she uses her creative skills and gentle manner to put patients, physicians, and coworkers at ease as she captures their message. Her sense of humor and willingness to help is always appreciated by members of her team. When not at work, Sonia enjoys excursions with her husband to San Francisco and spending time with family, both locally and in Southern California. So I know all of us are very excited to see her as Employee of the Month for May.
It is a lot of fun to see the hospital on Facebook.
Yeah, I mean, between Facebook and Instagram, and really, I get a lot of comments out in the community. They know much more of what's going on.
Great stuff.
So, yeah, and really, it's Sonia and that team, so.
Young folk.
Yes. All right, and now I'm going to talk a little bit more about our work in the community in terms of just going through our health promotion and community outreach events. All right, started in April, on April 10th, as you can see, we hosted with the Fremont Chamber of Commerce, the business forum with Senator Aisha Wahab, and we had about 60 people that attended in Anderson Auditorium. April 11th, I do just want to mention that we had nominated Rico Rodriguez, and he was basically, in terms of awarded by Assemblymember Alex Lee, the Unsung Hero Award, and this was for his work on the choking first aid education. I think many of you know his brother Kiko passed away from a choking event at their restaurant in Niles, and we've partnered with him and others in the community to be out and really focus on teaching those in the restaurant business or those who are servers to be able to really recognize and then also to help if somebody is choking. And I think I've mentioned we have saved life from that standpoint. As you can see, there's many others that we've been in the community, especially April 19th, Fremont Earth Day event, and that's always fun, and was participating in that. Moving on, you can see the other events in April. Dr. Brian Bonner, our orthopedic surgeon, talked about advances in joint replacement for younger, more active patients, and 172 views on Facebook and YouTube. You can also see the other things that we participated in with New Haven Days on April 26th, and also Maria Nunes did on April 29th, signs and symptoms of stroke. All right, again, our trauma team is busy in the community doing education around choking and for different groups. Dr. Wong did diabetes management. And I just want to pause a minute and talk about the event on April 30th, our community art open house. Really, we hosted a community art open house that really celebrated that intersection between art and healing and how important that art is in the process of healing. I want to just make sure everybody is aware. We have 2 new murals that are showcased between the main hospital building and Morris Hyman Critical Care Pavilion. And one was created by the Irvington High School, and another was created by Newark Memorial High School. And the murals are displayed next to, in the middle is the one that we've had for a while, the diverse community mural that was created in 2022. And so they really celebrate the vibrant, diverse cultures of Fremont, Newark, and Union City. So if you haven't had a chance to see them, I definitely recommend doing that. Also, that was featured that day were 4 new art pieces that are going to be going in the boardroom, and they are from artists Michael Nguyen, Cooksey Talbot, and Lilia Reynoso, and they really beautifully illustrate and reflect our values and truly sort of promote that healing and foster that sense of community. So those will be up in our boardroom. So we're excited to have that. And really, it's a reminder about the power of art. And I do want to just thank Susan Longini. She's a local artist, and she really helped us on this journey and spent a long time working with Stella to bring this all together. So. All right, as you can see, on May 3rd, Dr. Sunil Dewan did a free skin cancer screening and did it for 23 people. Moving on to May, again, we partnered with Alameda County Supervisor David Halbert, and we did a car seat safety event, and we installed 17 car seats and donated 3. Also, we've been very busy this last 2 weeks. We did celebrated National Nurses Week, and you can see all the different events that we've had. And then also, we want to recognize May 6th, we had presented 2 scholarships at the New Haven Schools Foundation Scholarship Awards Luncheon to 2 high school seniors. And moving on, you can see again in terms of the health fairs, and yes, we're in the middle of Washington Health Week, and you heard from some of our amazing staff about why they have come to Washington and stayed here. And then May 14th, tonight, Dr. Singh is talking about healthy lifestyles for kids. We have some pictures. And maybe you can stop for a second, Sri, on this. I just want to mention, great picture, but also that one of the, this is the 2 scholarships at the New Haven Schools Foundation. And just want to mention that Catherine Timbang is a daughter of one of our respiratory therapists here, Alan Timbang, and volunteer in the Service League. Catherine will attend UCLA in the fall and wants to be an L&D nurse. And the other one is Valerie Zavala Cruz, who is going to Cal State East Bay to study nursing. She earned her certified nurse assistant certificate while at James Logan High School and wants to be a special care nursery nurse.
Impressive kids.
Yeah, I heard. All right, you can see all the lists of the different events that we will be hosting. The rest of May will be busy in terms of education booths in different places, and also Facebook and YouTube, and again, our trauma outreach. Then we are going to be hosting, a behavioral health symposium for professionals, supporting resilience, connection, and professional growth. And this will be over 2 days, June 6th and June 7th. And you can see Dr. Karen Tribble is the director of Alameda County Behavioral Health. She'll give a keynote address. We'll have other speakers during that day. And then on June 7th, on that Saturday, we're going to do presentations and education for our community, and this will all take place in Washington West Auditorium. And then do just want to say that we, as mentioned, we have reached our fundraising goal for the Cancer Center, $12 million. Yay! Yes, and everything's moving forward with that. And also, we had a very successful 38th annual golf and bocce tournament on Monday, May 12th at the club at Castlewood. We're still calculating how much we raised, but I know the weather did not start off too well that day, but it ended better, I think. I believe it did. It was better than where it started.
It was better than before.
Yes, exactly. It was better than it started.
I think our ducks got wet.
Still not great.
Yeah, it was still a little chilly. I know some people were there, so thank you for participation. And then
People that spent that day there really ought to be
yes.
I'm sorry.
No, but in general, no, I agree. That I will say everybody it was still it was a wonderful atmosphere. Very festive and happy, and saw some really great shots going, and
I was really frankly impressed with the golfers putting up with that.
Oh, hey, the worst day of
the
golfing.
golf, I know. The golfers were great. They were very, very good. You have Mike and Terry and others and Ajay. Yes.
I expected to see half the golfers.
No.
Rain or shine, we're like the postal service.
That's supposed to make me laugh. Okay. And lastly, don't forget, save the date, October 11th is our 39th annual Top Hat. I think we have a few more. There's a couple of pictures from our golf tournament. Winning ladies on the left. Yep. All right. That is my report.
That's it.
Yep.
There's no other action items, no other announcements, so the meeting's adjourned.
Woo! Great.